Hey everyone, my name is Dr. Adam Nally. I'm a board certified family physician and a board certified obesity medicine specialist, and I'm coming to you today to do a video for the Keto 101 Summit, and hope you're enjoying the summit thus far. Hope you're enjoying all the pieces and parts that have been put together. I'm excited to be a part of this year. I was grateful to be invited by Dr. Lisa and her group and those that have assisted with this. So I hope all is well. I thought I would dive right in. They told me I only had 30 minutes, so I'm going to run through a lot of information, and hopefully it gives you some insight into expanding the use of a ketogenic lifestyle and really, truly ketogenic living, and how this lifestyle helps you unlock your life and your health through the use of ketones more frequently or more predominantly. For those of you that are wondering, you can find me at darkmuscles.com. My name is Dr. Adam Nally again, and I practice. I've been in private practice for about 15 years, about 18 years in total, including residency and training in this Phoenix, currently now the Northwest Phoenix corner of the valley. So hopefully that helps. And I'm going to try to do this together on one slide, so you're going to see slides and see me back and forth, and hopefully that'll be clear for you. It's important that I do this, that I do disclose some information. I'm the owner of darkmuscles.com. Many of you may know me from there. I'm a live streamer, a podcaster, and you can find those live streams on YouTube and on Facebook Live and those things. I'm the most recently, I'm the author of the Keto Cure, which was co-authored with Jimmy Moore, and some wonderful recipes by Maria Emmerich, who's actually in this program today, program this week. So hopefully you get a chance to see Maria and get a chance to listen to some of the amazing things that she does as well. I'm also I guess I got to put those up there. That's the book there. I'm the owner of the Keto Living brand. I helped develop the Keto Essentials multivitamin, which was something that I was looking for years for my patients, as well as berberine and some other supplements that are there. I'm a paid speaker for Novo Nordisk, and I'm also one of the distributors for the Prove It brand, exogenous ketone. So it's important you understand those are some of the pieces that I use in my business as an entrepreneur and also as a physician running my private practice. Those are some things that generate income for me, and so it's important to know that as we start off this area here. Anyway, in my office, calories are a swear word because they're essentially little tiny creatures that live in your closet and sew your clothes a little tighter every night. The challenge is that we've been taught for over 50 years that the calorie is king, that any calorie you put in has to either be burned off or it goes right to your waist and your hip bones. The challenge is that we don't discount the law of thermodynamics, meaning you can't matter can't be destroyed. It can only be changed in its form, and so we have to account for that matter. But one of the things that we often don't account for, and hopefully I can address in a clear way for you today, is how hormones affect that and change the perception of what those calories do. And so in our office, we don't count calories. We actually talk about hormones, what the hormones are doing, and we try to listen to the signals that those bring. And hopefully we'll be able to clarify that, because I know that's one of the big challenges that arises with a lot of what people are reading among the different ketogenic blogs and books and experts around the country. How do you put all this together? And hopefully I can tie this together for you more clearly. That's really what I like doing. Just to give you a little bit about me, if you've not met me before and don't know my story, this is my father. He was overweight his entire life. The Nally family struggles with obesity. It's one of those things that we as members of this genetic code we've got have a significant predisposition to obesity and to diabetes. And so as time went on, my father struggled cutting calories and watching his diet, and he ended up becoming a type 2 diabetic. He was on 150 units of insulin and 32 pills at this time when you see it here in the picture. This was when he visited me and my wife when we were in medical school, and just struggled to get that weight to ever move, and it was about 400 pounds at the time he died, and literally on 32 pills, and ended up dying at age 58 from all the complications of diabetes. The big issue is that bothered me was that his labs and my labs in our early 30s looked almost identical, and it's hard to tell. And as I was coming out of medical school, one of the things that I found, just like the majority of the population, is I struggled with weight gain, gaining 65 pounds through my training, and having a real difficulty getting that to come off, and worrying about the diabetes and the hypertension and the cholesterol issues that arise with that. I used to have triglycerides in the near 400 range, and my cholesterol was creeping. That's the big concern, and I saw that over and over in the first 5 years of my practice. One of the trends that you've seen, and I'm sure you've seen these slides before, is that in the 1985, only 10% of the population was obese. And then as we progressed to 2015, literally 35 to 39% is obese. And this year it's 40% obesity in a significant part of our country. And so that's actually really worrisome and very concerning. In fact, in 2007, when my family went on vacation to visit Disneyland, we noticed that the It's a Small World ride was closed. And that was one of our rides my wife really liked. And so when we asked, well, they said it's closed, it's being repaired. Well, what they didn't tell us is that they had to get larger buoyancy boats, because the old boats, if you remember them, were literally bottoming out and they weren't floating, and the ride was getting stuck. And because there was a 30% increase in body weight in the average American, and the ride was breaking down. And so they literally had to replace the entire flumes and the boats and create a better buoyancy boat. If you've ridden in it recently, you'll notice it's notably different. The boats actually float, they don't bottom out. And that's a big challenge. There are some significant non-medical costs to obesity and to the many diseases of civilization, which are the things I talk about in the book, The Keto Cure. The challenge is that 38% or 35.8% of the population is obese, 33% of us are overweight, 33% of our healthcare spend as of 2016, a couple of years ago, was on obesity and its related causes. That's $150 billion in healthcare in 2016. That's a huge amount of money. The challenge is that we've had to expand. Let me put it this way. Not only has it affected the economy, but it's changed the way employers and companies have to look at things. If you go to stadiums, they've had to increase the stadium size of seating. They've had to increase the braking systems on buses and public transportation because of this 30% increase in weight that we're carrying. Airplane seats have to become larger. I was an Air Force reservist, and they actually, during my time in the Air Force Reserve, they actually relaxed the medical qualifications for military entrance because of our weight. We couldn't qualify for military entrance. It's still a big issue. It's still a big challenge. They've actually had to increase toilet sizes in public restrooms. And lastly, this was one of the things that we dealt with as a family when my father passed away, was you had to get the extra large coffin, just even burial costs and those kind of things. So it affects all walks of life and all parts of life. And it's very, very scary to see that this is something that's happening over the last literally 25, 30 years. Very concerning. One of the things that we worry about is, how does this affect our children? Many of you know Barney, and the joke is in my office is that this is what happens when your life revolves around fishy crackers. It's one of those things that as we eat more and more and more starch, we see more and more of our waist circumference expand. This will just kind of give you a graphic that showing in the mid 1970s is when we all of a sudden saw this upswing in weight gain, not only just obesity but overweight generally and extreme obesity. Now the interesting thing is we look at that and say, well, what happened in 1975, 1976? And interestingly enough, we discovered lovastatin then. We discovered that there was this cholesterol drug that worked to help lower total cholesterol. But the other interesting thing is that this is the same time period when our food pyramid was created. Now it's a food plate, but the USDA guidelines came out saying this is what you should be eating, and it demonized fat. And so, as you can see, many people will claim that, well, Americans aren't reducing fat in their diet. I actually see that they are. In my practice in the last 15 years, patients would come in saying, Dr. Neely, I'm reducing the fat, I'm eating less calories, I'm exercising more, yet I'm gaining weight. And that was the same challenge that I found. I was giving a new pill for the diabetes that would arise. I was giving a new blood pressure pill every year, a new cholesterol pill. This is when literally the weight loss exploded in the United States. And that's weight gain, I should say, exploded in the United States. So big challenge. Unicorns are real. It's just that they started eating low fat in the 70s, and we now call them rhinoceroses. Is my little mantra that I use. Is that really what happens? Is that why our animals are more obese? Very likely. So I don't know if you've ever had this confusion, but on this diet you can eat all the steak you want, but a slice of bread's going to kill you. And on this diet you can have all the bread you want, but a steak will kill you. This is, Randy Glassberg was wonderful in some of his low carb cartoons, and this is one of his. And this just totally emphasizes the disconnect between the world and even in physicians saying, well, you can have this in there, and you can have this in here, and this will kill you here, and this will kill you here. And the question is really why, and no one has the answers for that. And that's been one of the big challenges that patients face, and that patients come to me just really because of this diet confusion that arises on a daily basis with people. So let's try to clear some of that up if we can. There's three constants in life. There's change, there's choice, and there's principles. Medical paradoxes are maintained by ignoring scientific principles. One of the things that happened was in the early 40s, 50s, and 60s, we knew that starches and sugars actually caused weight gain. We knew that. But we ignored this scientific principle because of a number of political and economic reasons. Our government basically said, hey, fat's bad, and so we all stopped eating fat, even though we knew sugar is what caused us to gain weight. And so that's one of the things that arose. And because of this medical paradox that's been propagated for almost 50 years, it's caused significant problems in our society. So in the words of Mark Watney, in the face of overwhelming odds, I'm left with I'm only one option. I'm going to have to science the crap out of this. And so that's really what I've had to do as a physician, is try to understand what's the real science behind it, because just telling people to cut the fat out and restrict their calories and exercise hasn't worked. And so that's one of the challenges as an obesity doctor and as a family physician seeing broad spectrum of disease. I'm noticing that all of these diseases like diabetes and hypothyroidism and Hashimoto's thyroid disease, high cholesterol, heart disease, these are all driven as diseases of civilization that started around the early 70s when we started doing this. Now, there are three massive studies talking about exercise and weight loss. And pardon my phone here as it's pinging at me. There are the three large studies that occurred, and these were low-fat, calorie-restricted studies. The first was the Women's Health Initiative, and this is 1991 for 8 years to 1999, almost 50,000 postmenopausal women, a low-fat group and a control group, and in that 8-year window of time, they lost a whopping 1 pound. Now, they claimed it was successful. I don't claim that's successful, but when you put a low-fat group on weight loss and they only lose 1 pound more than the control group that's not doing anything differently, that's a problem. And so we got 50,000 women that have demonstrated that low-fat calorie restriction doesn't work. The multiple risk factor trial, which is the Mr. Fit trial it's called, was a 7-year trial starting in 1972. It followed almost 13,000 men that were at high risk for heart disease. They were all placed on low-fat diets, and they were given instruction on exercise. They had a 100% failure to reduce weight or heart disease. Yet we quote this study all the time, yet it was an absolute failure in regards to reducing risk for heart disease and reducing risk for reducing weight loss. Big issue. Then the last one is the Look Ahead study, which was 5,000 patients. These are diabetic patients. They were supposed to be supported for about 13 and a half, 14 years, but they stopped it in about 9.5 years because it wasn't working. They had intense calorie restriction, about 1,200, 1,800 calories a day with personal dietitians and trainers that were helping these people support this lifestyle at home, and because of the intensive support, they lost about 6% of their body weight, but they didn't live any longer, and it didn't reduce heart disease. These are common studies that are quoted all the time about, look how great our cholesterol drug is, or look how great it is if we reduce fat and eat a good diet and exercise. Yet this is 67,000 people over 46 years of time that had absolutely no success in reducing diabetes, reducing heart disease, reducing weight, or the other factors that are there. And so this is very scary, and it's a very concerning issue. We've been taught this energy balance model, that there's a calorie in, calorie out issue, that we should exercise, and if we eat more calories, we got to burn them off through exercise. And so we've been brainwashed into this calorie is king component. Then there's this hormonal model, which you're hearing more and more about, which basically says we eat food, and that food has a hormone stimulus, and it has some genetic change and some hormonal change that arises that way. But this is the only model that actually accounts for metabolic syndrome that we see with diabetics. We don't see, like my father exercised, he reduced his calories, yet he still gained weight, which didn't make sense from a calorie model. Now, if you can argue, a number of reasons for that, but the challenge is that when the patient themselves, 90% of the time, don't see success and they do it over and over and over again, they think that we call that insanity, and the patients stop doing it. It's not successful. 80% of, this is the big problem I see, 80% of individuals cannot maintain greater than 10% weight reduction for over 2 years. We've seen that and time again. There's at least 4 studies that show that. And as an obesity doctor, this is the biggest hurdle that I try to overcome, yet no one talks about this. They'll say, oh yeah, my diet causes weight loss in 16 weeks, but those patients, 80% of them regain the weight within 1 to 2 years. We don't talk about that. And the challenge is that the thermodynamic approach, when we look at the energy in, energy out balance approach, this approach, when we throw this at people, is not successful in the long run, over 2 years. That's the big issue. It really points to the fact that this is hormonal, and we need to look at that. And so we're going to dive into that a little more. Good judgment comes from experience, and most of that comes from really bad judgment. So we learn as we go, and that's the one challenge in science, is that we attempt to apply the principles we think we gain experience, and that gives us better judgment in what we do. This is me in medical school, and I don't know if you can see my mouse, but I was gaining, and at this point I think I was about 50 pounds overweight. I gained about 65 pounds more than I am today when I came out of residency. And then after I started applying the principles of a ketogenic lifestyle, you can see this is me a few years later, having just basically cut the carbohydrate out and started increasing the fat and moderating my protein. Then when we added exogenous ketones later on, I found that was even more effective in a number of things that we're going to talk about here in just a minute, and how those exogenous ketones play a role, at least in many people, including my life, in modulating and helping the ketogenic lifestyle. So we'll talk about where those fit. Low carb diet's bad for you. One of my patients slipped on some bacon and grease and broke her toe. I actually had a patient do this. So I'll tell you, if you're cooking lots of bacon, just be careful, because the floor gets a little slick and you may slide and break your toe. So just be careful there. All right, as we move to the next slide here, what really is the cause of obesity? Now, I've implied it's glucose and sugar. 85% of disease is driven by this insulin resistance, which is a mechanism of regulating fat metabolism. Now, one of the questions is insulin resistance a disease, or is it a protective mechanism or a defensive mechanism? The challenge is that it's regulated in 3 different ways. Our blood sugar, and this insulin resistance, is regulated through hormones. It's regulated through an allosteric mechanism, which is basically these are substrate supply, which means if you've got more glucose, it drives the process, or if you have hormones, it drives the process. And lastly, epigenetics. We know that being in ketosis, the ketones themselves actually stimulate the production of different genes to be activated and other genes to be inactivated. And that's what epigenetics means. And so hopefully that'll give you some understanding that this is a complex mechanism, obesity is, and it's really mediated in 3 different mechanisms or 3 different ways. And so we have to understand all 3 of those ways. If we just say, hey, stop eating, that's an allosteric approach, but that allosteric approach only works for maybe 1/4 of the population, because the other 3/4 of us have significant epigenetic issues and hormonal issues that are involved there. Essentially, insulin resistance is a dysregulation in the way the body distributes energy through those 3 mechanisms, so it's important. But insulin is the primary player, and the challenge is if you don't fix the insulin first, you'll have major issues fixing any of the other issues, including obesity, diabetes, and all those things. So the key player initially is we got to fix the insulin issue. Now, insulin resistance is essentially an overproduction of insulin. These are people that are producing between 2 and 20 times the normal amount of insulin. It's called hyperinsulinemia. You may hear that term. You may hear insulin resistance. You may hear metabolic syndrome. These 3 are all interchangeable phrases or words, and they all imply that there's an excessive amount of insulin being produced in response to a single starch or sugar or carbohydrate ingestion. Important. Now, 10 to 15% of obesity may also be related to sedentary changes in lifestyle. Yeah, we know that. It's important to understand that, and we look for that in the office. And then 5 to 10% may be other metabolic deficiencies, including genetic disorders that also there are, like Prader-Willi and some other things that can occur. And so your physician should be looking for those when they're looking at obesity. But in regards to the insulin resistance factor, this is really 85% of the cause when people walk through my door, 85% of them have insulin resistance. So the weight that we gain or lose is driven by hormones, not by calories. Real important. That's the main concept. So what exactly is insulin resistance? So this slide is a slide that I developed in conjunction with Dr. Kraft and some information that he published in his book called The Diabetes Epidemic in You in 2011. And it's something that I started seeing when I first came out into practice. Now, normal insulin fasting should be less than 5 I think that's micrograms per deciliter, and I'm sorry, it's millimoles per liter. Pardon me. And then 2 hours after a meal, that insulin level should be less than 40. If you're above that, you fall into stage 1 insulin resistance. And if you have skin tags, I guarantee you're in stage 1 insulin resistance. Stage 2 insulin resistance is where you see a fasting sugar, or fasting insulin, pardon me, between 60 and 30 millimoles per liter. And 2 hours later, after a meal, it'll be 40 to 90. Stage 3 is essentially 11 to 30 in that fasting range, and then 90 to 150. And then essentially type 2 diabetes is stage 4. So we've arbitrarily called diabetes and put it in this box and said this is diabetes, but yet the disease that's driving diabetes is actually happening 20 to 25 years before we ever hit type 2 diabetes. These patients are patients that have a fasting insulin of greater than 31 millimoles per liter and greater than 150 millimoles per liter at 2 hours after a meal. Now the challenge is, like my father, after a while that pancreas burns out and then you stop producing insulin, and so you'll actually see that insulin level drop back down under 5, and it'll be somewhere between 5 and 20, and it'll look normal, but yet the person will be diabetic. And so these are patients that have been hyperinsulinemic, and they've overproduced insulin for such a long time that the pancreas burns out, and now they cannot produce enough insulin to keep up. And so that's end stage type 2 diabetes, or they progress to type 1 diabetics, meaning they're insulin dependent. Now, type 1 diabetes, if it was juvenile onset or younger, is usually the pancreas was damaged in some capacity, and people can't and those people don't produce insulin on their own. So it's important to understand that's a challenge that arises with those people, and that they need insulin. So that's a type 1 diabetic makes no insulin whatsoever. Type 2 diabetic makes too much insulin until they reach that 5th stage. And hopefully we try to keep them from getting there. That's the important part. So I don't want to demonize insulin, because we need a little bit of insulin to function. Our cells need it. A baseline level of insulin, and a small amount that rises when we ingest glucose, is essential. But when you have an overproduction of insulin, when you produce too much insulin, the challenge is that you see inflammation, you see weight gain, which we've talked about. Insulin affects the kidneys and causes sodium and potassium retention, and it raises the blood pressure. It's amazing to me that within a couple of days of someone cheating on their ketogenic lifestyle, their blood pressure goes up and they swell because of this particular issue where your body hangs on to sodium and potassium. The amazing thing is that increased fructose and sugars and the high insulin response thereby increases uric acid production as well as calcium oxalate production. So it increases the risk of uric acid kidney stones as well as gout, and it increases calcium oxalate, which relates to kidney stones as well. So if you've had kidney stones, you have insulin resistance. I can almost guarantee it 100%. Insulin raises the small dense LDL particle. Now, LDL is the LDL is the bad cholesterol, we've called it. Yet LDL actually has 3 subtypes, and the big fluffy and the medium-sized subtypes are not heart damaging, or they're not heart disease producing, but it's the small dense ones, or the SD-LDL that are. We know that insulin directly increases small dense LDL particle number, and that it's that small dense LDL particle that is the atherogenic particle. Insulin also directly increases triglycerides. The small dense LDL particle and triglyceride run together. Insulin increases free radicals. These are not the terrorist type. These are the type that are produced by excessive beta oxidation or by oxygen breakdown particulates that increase the risk for cancer down the road, and that's driven essentially by insulin's presence in metabolism. So if you have a high insulin load and you're oxidizing fat, you actually see the production of free radicals. Thyroid peroxidase antibodies go up with a high insulin level, which increases the risk of Hashimoto's thyroiditis. In men, their estrogen goes up, and in women, the estrogen goes down. It causes a flip, and we'll talk about that later today. And then testosterone goes down in men and goes up in women. We'll talk about that as well. Lastly, inflammation is driven hugely. So any inflammatory disease that you may have, if your insulin level is 2 to 20 times normal, you're going to have significant inflammation, and it's going to cause a problem. So how do I know this, and how do we know in regards to how insulin drives fat? Well, there's only one hormone that when you ingest your meal, let's say you eat your food, let's say that you have a piece of bacon, you eat your bacon, and the fat that's in the bacon actually it's absorbed into the gut, and it's in the gut wall, it's absorbed into what are called chylomicrons. So the fatty acids are pulled inside a little round, basically a shuttle bus, and that shuttle bus goes up in through the lymphatic system and then comes down through the arteries. And as it's moving down through the arteries, if insulin is on, let's say it was bacon and you had oatmeal with it. So you had your oatmeal, your insulin spiked, and then you had your fat with the oatmeal. That insulin says, hey, we got to use the sugar first. There is an oxidative priority, meaning it's going to use the sugar before it's going to use the fat, because we can store the fat for a rainy day or a famine, but we can't store the sugar. So we're going to burn the sugar first. So as that fat is moving in the chylomicron, this little molecule, essentially the largest form of a cholesterol bus, as it goes through the artery, it actually docks like the Starship Enterprise with this lipoprotein lipase, and the only thing that turns lipoprotein lipase on is insulin, and that pulls the fat into the fat cell, and it's stored in a lipid droplet, and that's essentially where your fat goes. So if insulin isn't on, you will not store fat in the fat cells, period. If you've ever seen a type 1 diabetic who doesn't take his insulin, who's truly type 1 diabetic and doesn't make any of his own, he or she is skinny as a rail, because insulin is what drives the fat into the fat cell. Without the insulin, it doesn't go in. Now, when insulin's high, it goes in and it can't get out. When insulin's low, it doesn't go in and it comes out easier. And we may have time to talk about that a little as well, but it's important to understand that insulin is the primary mediator of weight gain and of these diseases, and we've got to bring the insulin level down. So if your insulin is 20 times normal, guess what you're doing to those chylomicrons? You're storing 20 times more triglyceride into those fat cells than the average person is, and so that's important for you to understand. So change starts, and this is my horse Bailey, change starts when someone sees the next step. Hopefully you're seeing this, or you already know this, and it's helping you. So let's look for just a moment, excuse me, at a little bit of fuel use. It's important to understand there are essentially 3 macronutrients, and you've probably heard this already through this program, but there's protein, there's carbohydrate, and there's fat. Now, the key here is that any of these fuels can be used to create this little molecule called ATP. This is adenosine triphosphate. Your body has to have this for the muscles to contract and for the heart to beat, for enzymes to react. Excuse me, you got to have this ATP, which is basically the fuel. It's the fuel system. It's a transfer of electrons, which essentially acts like the money inside the body. It's how cells exchange energy. It's the energy exchange medium is what I'm looking for. This ATP is key. Now, let's say we don't have any, let's say we eat a donut. We have a carbohydrate and we have fat together in this donut. Well, what happens is the body has to signal that we've got both fuels here. So as you eat, when the carbohydrate's present, the body says, hey, we're going to use the carbohydrate first because we have no real way to store this for very long. And we know we can store fat for a rainy day, so it produces insulin. And that insulin shuts off the production of fatty acids into the Krebs cycle and shifts them into storage of the adipose to make it in a roundabout way. So it'll drive the process of moving the sugars or the starches or the carbohydrates through the system and shunt the fat to storage until there's no longer carbohydrate available, and it can be used another day or in a famine. We haven't seen a famine in 100 years. That's one of the other problems that arises. We have carbohydrates aplenty, and so our insulin is always on. And if you're insulin resistant, you're producing 2 to 20 times the normal amount of that insulin, and that's a big problem. All right, well, let's look at what happens if we don't eat any carbohydrate. Well, let's say we take away the carbohydrate, we just decide to have protein and fat, or just fat. Well, the protein has to be used to make enzymes and to make skin and hair and things like that. So the body knows that. So it's going to be very protective of using the protein, and it'll use it last. In the way the body's metabolism is set, protein really will be used last in the face of the absence of fat. So the protein will be shunted. It can be used for fuel if necessary, but let's say we didn't eat any carbohydrate, so there's no insulin. So what will happen is that fat will then go through the liver. The fat in the system is actually converted from glycerol, which is free fatty acids, into beta-hydroxybutyrate, acetoacetate, and acetone. These are the 3 ketones that are created. So free fatty acids in the liver are converted into ketones in order to be used as fuel in the liver. So the liver can use the ketone, and the liver can also use and it can send that ketone onto the body. Now, why would the liver make ketones instead of just letting the body use free fatty acids? Well, in the first few hours of fasting, your body's just going to use the free fatty acids in a process called beta oxidation. The other cells can use free fatty acids without ketones. But what happens in the process of using those ketones is very costly because it causes the body to break down protein at the same time. So the body doesn't want to do that, and so it knows in order to protect the protein, then it'll convert those free fatty acids in the liver into ketones, which can be used without breaking down the protein, and it can stabilize or keep you from using that protein and that leucine. It preserves it, so you don't lose muscle mass through the period of fasting or starvation. And so that's why this method works. And so you create ketones as the exchange mechanism for fuel from the fatty acids, and you can do so by preserving protein. So that's important to understand there. All right. The ketones that you make are these acetoacetate beta-hydroxybutyrate. These are also the exogenous type ketones that you can take internally or drink. They're the same thing. It's basically this beta-hydroxybutyrate right here. So really important to understand there. All right. If I take you off of glucose and I put you on ketones or free fatty acids, I'm essentially taking you off of unleaded gasoline and I'm putting you on diesel. That's really what we're doing. So that's one way I look at it. So how do you do this, Dr. Nelly? Well, one doesn't simply lower the carbohydrates. It's important to understand that we've been told to do low-carb diets, but not all low-carb diets are the same. Paleolithic diets traditionally are 100 to 250 milligrams of grams of protein per day. But for people like me, lowering that carbohydrate isn't low enough for me to shift my fuel source to using free fatty acids and ketones alone. Low carbohydrate diets are about 100 grams or less per day. Then there's very low carbohydrate diets, which are less than 50 grams per day. And then ketogenic diets, which is what I focus on with most of my patients, are less than 20 grams per day. Many of us who are insulin resistant have to lower that carbohydrate level to at least less than 50 and often less than 20 grams per day to be fully effective in turning down the insulin drive enough to access the fatty acids and the ketones available as fuel. That's key number one. So you've got to understand that. There's a group of people that do really well with Paleolithic diets, and most of the time these are people that are doing heavy intensive exercise, like the CrossFit folks. Because of the intensive exercise and the mild carb restriction, they actually are able to access those free fatty acids and ketones intermittently, and they actually see success. But for someone like me, that never worked. Even when I was running triathlons, it didn't work. I had to lower the carbs all the way down to less than 20 grams per day to be effective that way. This is called oxidative priority, and I put this in here just to understand that your body will first process alcohol, then it will process protein, then it will process carbohydrate, then it will process fat. That's the order in which it wants to use fuel in that regard. If you're absent, well, let me put it this way. If you have all three, it's going to use these three this way in regards to its priority in oxidation, and that's just to help you understand that component there. One of the recent journal article questions is they said, well, you know, if we've demonstrated that it's all calorie, or the calories are the king here, and they say, why then do popular self-help books and scholarly articles and media headlines still question the validity of dietary calorie? Essentially, a kilocalorie being 1,000 calories or 4.2 kilojoules in predicting energy deficit and accumulated excess. And the second issue is they say, well, why, despite more being known about energy management than ever before, does our society appear incapable of managing otherwise simple energy balance? They're basically saying, why are so many people overweight and fat? Because we've told you it's all the calorie. And if you'll just exercise more and eat less, you'll lose weight. Well, I'm here to tell you that 85% of the people in my office that have tried that have not seen success, myself included. And so my concern is that this is what the literature often points to, and it often says, well, we just live in a gluttonous society, and you're just lazy, you're not exercising enough, or you're not eating few enough calories, and it's causing you to have significant weight gain. And that's actually not the problem. And the reason is this. Well, let me put it this way. It makes us overwhelmed. So it actually we start to ask, is it insulin? Is it calories? Is it inflammatory foods? Is it exercise? Is it thyroid? Is it estrogen? Is it testosterone? I could go on, but it starts to make people ask these questions. And often when they ask their doctor doesn't know. And so the doctor says, oh, just exercise more and eat less. And we don't like that answer because it doesn't work. That's the challenge. So let me put it this way. If my glucose drops and your glucose drops to less than 80, your insulin level will decrease. We've got to bring those levels of insulin down to the baseline normal levels. When your glucose drops to less than 70, your body kicks out glucagon and epinephrine. This is a hormone signal based on the level of glucose. When that glucose drops to 67, you start producing norepinephrine and growth hormone. At less than 65, cortisol rises. At less than 55, you start having the autonomic nervous system kick in, and you get dizzy and lightheaded, and you have low blood pressure and sweats. And when your blood sugar drops below 50, your brain function becomes impaired. These are hormone signals telling your body that it no longer has the adequate glucose it needs to support the brain function. So the body will then shift to using fat or protein. And this is the signal. We have no calorimeter in our body. There's nothing that says you ate too many calories. What the body knows is the blood sugar dropped too low. And that's based on hormone regulation. And then we're going to look at that a little closer. So this is the fat cell. I want you to understand that there are essentially 5 reasons your body loses fat out of the fat cell. Reason number 1, your insulin drops low enough to turn off the signal to hold on to the fat inside the fat droplet inside the cell. You got to do that first. It's number 1. Number 2, epinephrine and norepinephrine go up. These are hormones that activate this mechanism right here, opening up cyclic AMP to be available, and then open up these 3 little hormones that let the glycerol and the free fatty acids exit the fat cell. That's epinephrine. What stimulates epinephrine and norepinephrine? Exercise, activity, being physically active. So people say, well, you got to be physically active, but yet they don't turn the insulin down, and that's where they fail. That's where a lot of people fail. Before you can actually see success from exercise, you have to turn the insulin down. It's essential. Number 3 are the anti-lipolytic receptors. These are receptors that actually do the opposite. These are nicotinic acid. These are prostaglandins. So stress, inflammation. Protein YY is actually stimulated from the gut, meaning I ate a meal. I'm now going to slow down my release of free fatty acids. Neuropeptide Y, adenosine R. These are all hormones that do the opposite of the catecholamines. Number 4 is related to atrial natriuretic peptide. Now, ANP is amazingly stimulated by the heart. The more the heart contracts, the more ANP is produced, and you actually activate more release of free fatty acids. And the reason is the heart loves free fatty acids. It works better on free fatty acids than it does on glucose. And so the heart knows that if it has to squeeze stronger, it'll release that more effectively. Now, the amazing thing is we know that when we give you exogenous ketones, it actually increases your heart rate by up to 25% and increases the squeezing capacity of the heart up to 75%. And that's because the ketone stimulates atrial natriuretic peptide, and that ANP then stimulates release of free fatty acids out of the fat cell. And so the heart actually does better in the presence of a ketone, whether you're making that yourself by your body's fuel type, or whether you're adding that through an exogenous ketone form. We know that actually plays a big role there. So that's why I'm a big fan in certain body types and certain issues to help use ketones. And then last reason, or the last doorway that lets the fat cell open, is our PPAR agonists, glucocorticoids, and fasting. These are actually, PPAR agonists are actually stimulated through the bile acid release, and so depending on the types of fuel you put in the gut and the more bile acid you create, the more free fatty acids you may release. Fasting does this. Some glucocorticoids do this as well. So it's important to understand these are the hormone mechanisms that are telling your fat to open the doors or close the doors. The one door in is insulin, but insulin has to be on for fat to enter the cell. Then when insulin's down, fat can exit the cell, but then there are 5 other back doors that can let that fat out. And so we want to try to modulate those all together as effectively as we possibly can. And I'm hoping these are the circles are all these 5 areas. All right. So the other component, and the other reason that a calorie is not a calorie and a calorie is not king, is that when you become an obesity physician, you get to memorize all these exciting hormones. There are over 32 different neurohormones that relate to the way our body craves or doesn't crave food. If it's in red, it means it's decreasing hunger. If it's in green, it means it's stimulating hunger. The challenge is that when I give you fructose, which is 1/2 of a sugar molecule, there's a glucose and a fructose. When I give you fructose, fructose actually shuts down the arcuate nucleus of the brain so that you get less decreased hunger stimulus, and you actually have an increase in hunger because of this, the byproduct of fructose metabolism in the liver. It's a very similar aldehyde, similar to what alcohol is metabolized by. So when you drink alcohol, you actually get hungry, you crave more later. It's because of the way it stimulates the hypothalamus. And that's what drives these repeat cravings with fructose. So it is hedonic, meaning just because you cut your calories and you exercise more doesn't necessarily mean you're not going to crave the food. And you know, and I know that if you stand in a room full of donuts for 3 or 4 hours, you may eventually eat one because the cravings just get immense. It's kind of hard not to do that. So be aware of that. We know that from these studies. So this is where glucose stimulates the brain. So in the brain that was stimulated by glucose, the frontal component of the brain is functioning. But if you give fructose to the brain, we actually are shutting down in the blue area here on this positron emission MRIs. show areas of decreased activity. So fructose actually shuts down the hypothalamus of the brain, so you're not getting the signals of satiety that you normally would get as effectively. And so it's actually very, very important to understand that. GLP-1, when our stomach stretches, also goes to the brain and tells your body you're full. Well, fructose stops that from signaling as effectively as well. So this is, again, another reason. There are multiple hormonal reasons that our body may or may not be hungry, and it's not just because you cut the calories out and you exercise more, and that's the challenge. Those are two parts, but it's not the whole key here. And this is where I see 85% of the population struggle. So does the body really require 100 milligrams of carbohydrate for adequate function? A lot of people will say to me, and I've had nutritionists say, well, Dr. Nally, you can't cut the carbohydrates back that far because the brain will die. It has to have sugar. Well, yes, your brain needs about 100 grams of carbohydrate per day. Your liver makes 240 grams no matter what you're doing. And it's important to understand that. Your brain needs glutamate, aspartate, glycine, and D-serine because they can't pass through the blood-brain barrier, and it uses these to form neurotransmitters. The brain doesn't actually need it for fuel. The brain can use ketones for fuel, but it needs the glucose to make neurotransmitter molecules like serotonin, dopamine, and norepinephrine. And that's really why the brain needs those 100 grams every day. All right, so what are the 12 benefits of nutritional ketosis? I'm going to put these in here so I don't go over my time. So improve biomarkers of health. We reverse the diseases of civilization. We increase fat loss. We sustain energy. We see improved mental functioning and clarity. I see improvement in dementia patients. I see improvement in patients with multiple sclerosis and neurodegenerative diseases. We see improvement in nerve function when we shift people into ketosis and we give them ketones as their fuel. We see increased strength and endurance. We see decreased inflammation, improved recovery, improved muscle preservation, appetite control is better, they feel better, and people are able to maintain weight greater than 2 years. Again, that's what I've been looking for such a long time, is what dietary approach allows a person to keep the weight off for more than 2 years. And a ketogenic lifestyle is what does that. Above and beyond any other dietary approach, this is what does that. And so that's why it's so important. So what I want to just see here is that this is the liver here, and the liver is producing glucose continuously, and it's producing it for the brain. It's trying to make sure that there's somewhere between 70 and 100 grams of glucose in the bloodstream for the brain's access to make those neurotransmitters. Now, there's a feedback mechanism. Because the glucose is being produced, the pancreas is then kicking out insulin, and there's this nice balance. So it's not the pancreas that regulates our blood sugar. It's the liver that regulates our blood sugar. And the feedback from insulin is that helps to control it. It's kind of the brake on the liver. So the liver's producing glucose through glycogen and through gluconeogenesis. And so you're making glucose through what we refer to as glycogen synthesis, and it's producing this glucose continuously. And it wants to maintain that. Pancreas is producing insulin to be the counterbalance or be the brake to kind of keep that from overshooting the mark. Now, the fat cells, we now know that our fat cells are the largest endocrine glands of the body. And the challenge is that the fat cell makes 5 different hormones that influence the way the liver produces glucose. And amazingly, when the fat cells get bigger, they get fatter, they overproduce adiponectin, leptin, resistin, interleukin-6, and tumor necrosis factor alpha. The challenge is that adiponectin actually has an inhibitory effect on gluconeogenesis, but resistin has an amplified effect on gluconeogenesis, and tumor necrosis factor alpha actually shuts down the effect of insulin on that. So what happens is you have this overmodulation of glucose. So what happens is the glucose level goes up. So in a person who's insulin resistant, we see a rise in their fasting blood sugar above 100. Your blood sugar may be 102, it may be 103, it may be 110. That's because your fat cells are telling the liver to make more sugar. And insulin can't keep up, so the pancreas produces more insulin. So you see a rise in insulin. So you'll see a rise in 2 to 20 times the normal amount of insulin in response to the liver's regulation of that glucose because of the overdrive stimulated by overfed fat cells that are overstuffed and they're overproducing hormone inappropriately. And that's the challenge that arises there. So it's very, 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 very important to understand. We know that tumor necrosis factor alpha itself actually slows the release of the fatty acid from the back of the fat cell and actually increases the weight gain even more. So if you have an inflammation, if you have a cancer, if you've got something that's driving that tumor necrosis factor alpha, that also occurs as well. There are 2 other hormones, omentin and vispatin, that also decrease the effect of the liver of gluconeogenesis, but we're still learning about those. Those are brand new hormones we just discovered in the last year. So important to understand these factors, and important to understand these 3 things and how they work on the body. Now, the amazing thing is this: when I put you in ketosis, when I take away your carbohydrates, the ketone actually, through the production of carnitine and the way it has an epigenetic effect on the FGF21 DNA section suppresses the overproduction of these hormones from the adipocyte and lets the blood sugar balance back down. So one of the reasons I'm a big fan of putting you in ketosis is I can actually almost immediately, within a few days to a week, improve your overall overproduction of glucose in the liver and reset the liver back to normal in putting you in ketosis. Now, in many cases, sometimes that's harder, especially with excessive fat. So that's where we use exogenous ketones. I actually use that to damper down the overproduction of insulin from the liver and control that gluconeogenesis rate by adding exogenous ketones with the use of a ketogenic lifestyle. So that's how I use them. That's why I use them. So the challenge is that this is a slippery slope, and I've kind of shown this already, but obesity increases the insulin resistance with hyperinsulinemia. It leads to impaired glucose tolerance, meaning you're overproducing glucose. That leads to early diabetes. Over time, the beta cell dies, and you have beta cell failure, and you end up in late-stage diabetes. The challenge is we've been told we need to cut out the fat and increase the carbs, and this vicious cycle drives this whole process and has been for over 50 years. The amazing thing is this: insulin resistance is reversible in 18 to 24 months in many cases. I have multiple type 2 diabetics that are no longer type 2 diabetic by definition because we've now reversed and normalized their insulin loads. We've reversed their blood sugars, their cholesterol, and their blood pressure are now better, and it's amazing. It's amazing to see. Now, I told you about the balance system of the liver. The liver does something else important, and this is where fructose, which is, again, one half of a sugar molecule, plays a big role in the diseases of civilization. So I'm going to point these out. These are things that I talk about in my membership site. These are things that I talk about on my live streams. This is what my book talks about, The Keto Cure. So if you're interested in this, you want to really go get the book, number one, check out my membership site, because this is where we dive into this, and I'll give you a lot more information here. But what I understand is when fructose is metabolized in the liver, it's metabolized identically to alcohol, and it increases uric acid. And uric acid actually suppresses nitric oxide, and nitrous oxide, when it goes down, lets your blood pressure go up. So what I'll see with people is they'll come to me literally after the holidays. This was actually quite fun to see after, well, it's not fun, but it was amazing to see after the Easter holiday when all the families had Easter candy, and all of a sudden 2 days later, all the dads showed up in my office with high blood pressure because they cheated, their uric acid spiked, their nitrous oxide went down, and their blood pressure spikes. And they receive water retention, and their varicose veins get worse. It happens every year after every holiday. I almost continuously see it. So this is the driver. And amazingly, when I correct and I eliminate the sugar from your diet, I will see blood pressure normalization in somewhere between 2 to 4 weeks because of this pathway specifically. Now, the other thing is that uric acid drives gout. And those of you that have gout, I apologize to you ahead of time, but it's your own fault. You've been eating fructose or someone snuck it in your diet. So you need to be careful of that. And then lastly, oops, let me pull up my screen here so I can see myself and see what I'm doing. Lastly, oops, one more there, kidney stones. I actually experienced this. I went to a family member's house, was given some pulled pork, which actually tasted really yummy, and I was so impressed by the flavor that I asked the person that made it for me, I said, how did you make that? What was in it? And the person told me, oh, we use Splenda. And I went, uh-oh. Splenda contains maltodextrin, which acts very much like fructose, and it's a sugar, and it spikes your uric acid level, and you end up forming a kidney stone. Now, the other alternatives, the challenge is if you get dehydrated and you have calcium oxalate, the shift in the sodium and potassium causes the calcium oxalate stone to form in the kidney, and that usually relates to high insulin load in the presence of dehydration can cause the calcium oxalate stones to rise versus fructose causing uric acid stones. The challenge is I ended up with a kidney stone for the first time in my life, and I thought I was going to die. It was bad. For those of you that have a kidney stone, I now understand a new level of pain, but I realized that this is what happens when you have excess fructose or you have excess sugars in the face of dehydration, and this is one of the things that can happen. So again, 3 of the major diseases of civilization can be dramatically improved by just reducing sugars and starches in the diet. So let's look at the heart. We talked a little bit about how the ketone actually increases heart rate and increases blood flow by up to 75%. I see multiple patients with improvement in contractility and function, especially those with heart failure, have notable improvement over a period of 1 to 2 years because of how the ketone stimulates this increased squeezing capacity of the heart. And that releases this ANP hormone, which actually helps with that whole process along the way. Now, vascular disease, stroke, heart attack, these are driven by atherosclerosis, and atherosclerosis being driven by an abnormal cholesterol level. Now, it's not total cholesterol and it's not LDL-C. What happens is this: with elevated insulin, you see an increase in your C-reactive protein. That C-reactive protein, even at age 10, will start to lay down a fatty streak within the artery of the body. So that we're cutting your artery in half here. You're seeing the wall of the artery. This increased inflammation, excuse me, that's constantly driving is what causes that fatty streak to arise. Second, cytokines and something called toll-like receptor gene number 4 cause increased process, and the cytokines get inside this fatty streak, cause a fibrous cap to form. And then what happens is you have what's called pregnancy-associated plasma protein, or PAPA-A. This actually causes further instability of that fibrous cap. And then what happens is you start getting more small dense LDL particulate pushed in, and then macrophages enter, and that's all driven. That's what drives this process to happen. So these 4 hormones are high because of insulin. And then the lipoprotein-associated phospholipase, LPLA2, which is a component on the small dense LDL particle, which is driven into that unstable cap, then leads to further rupture of the cap and either a blockage causing a stroke or a blockage causing a heart attack. This is the driver behind atherosclerosis, heart disease, and stroke. And it's not the fat, it's actually the sugars spiking the insulin in an excessive amount. I've been amazed to see the reduction in these. As we cut the carbs back, we see a reduction in that plaque formation, and we may talk about that here in a little bit. Thyroid. I get more questions about the thyroid than anything. So the important thing to understand is that the hypothalamus produces what's called TRH, thyroid releasing hormone. That TRH then stimulates the pituitary gland to produce thyroid stimulating hormone. Thyroid stimulating hormone then stimulates the thyroid gland to produce a number of T's, T7, T4, T3, and all the T's in between. But the 2 key players here are T4 and T3. T3 goes right onto the blood cells, all the cells of the body, and acts like the gas pedal on the metabolism, increases the metabolism or slows it. And as you saw in the fat cell earlier on, the T3 and the T4 drive release of free fatty acids in those cells and help the cell handle its fuel partitioning based on the metabolism and the metabolic need. T4 is converted into T3, and the remaining T4 that's not used feeds back up and tells the pituitary how fast the thyroid's working, and this is the governor on that system that helps that system function well. This works all great until you introduce overstuffed fat cells and sick fat cells that are and an increase in insulin. So we see an increased insulin level. That increased insulin level actually adversely suppresses a couple enzymes, specifically insulin-like growth factor 1, and it actually stimulates the presence of increased thyroid antibodies. So your Hashimoto's thyroiditis is driven by a high insulin load. I see it frequently. I see it very often. So high insulin can lead to Hashimoto's thyroiditis, which then throws off the whole issue, and you can either be hyperactive or overactive or underactive on your thyroid function because of those thyroid antibodies. The antibodies essentially look at your thyroid and say your thyroid's foreign, it attacks it, and your thyroid's not functioning very effectively. Second, a high leptin level. So your fat cells overstuffed, they produce excess leptin. That leptin signal is supposed to go to the brain and tell your brain you're full, but you're not getting the full signal, so it produces more. So your leptin goes up and up and up, and so we see leptin resistance as well as insulin resistance at the same time. And that excessive leptin resistance actually rapidly converts T4 into T3, and giving you more T3 is like giving you speed. Your heart takes off, you get a little jittery, you get shaky, and that actually increases the risk of conversion there, which then can cause either hypothyroidism or hyperthyroidism, depending on how the feedback is affected. So you can actually see that from both of those factors, and that's the thyroid in a nutshell. So what kicks you out of ketosis? What is going to cause an adverse problem with ketosis and keep you from having the benefits of what we've just talked about? Well, anything that raises your insulin, so complex sugars, simple sugars. And when I say complex sugars, I'm talking about root-based vegetables, so potatoes, carrots, corn, even peas. These are carbohydrate-based. They're complex carbohydrates. And people say, well, Dr. No, they're good carbs. Yeah, but they're still sugar. And whether that sugar spikes your insulin at 1 hour or spikes your insulin at 3 hours, it's still sugar. It's still going to spike it, essentially. And it's the insulin problem, not the sugar problem itself, that we have the challenge with. That's great. Now, the leafy greens are fine. You can have all the leafy greens you want, but if it's not a leaf and it's not green, it's a complex carbohydrate. And a lot of people say, well, Dr. Nelly, I took my leafy greens and I blended them, and I juiced them. Well, if you mechanically break them down through a blender, you juice them, you cook them, you're going to activate more of the sugars as well. And so I have a lot of people coming into me with their green drinks, having a spike in their insulin and their blood sugar and their weight gain halts because they're drinking their yummy green drinks. Now, I know people love their green drinks, and I'm making a little bit of fun of that, but the challenge is if you mechanically break down those long chain fibers, you're going to activate the sugar, and that's another way that it can kick you out of ketosis. Sweeteners, got a whole article on those that's on my website at docmuscles.com. You can see that. But I got a list of which sweeteners are okay and which ones aren't. The big culprits that people sneak into things are xylitol gets snuck into a lot of things. Sulfame potassium is the new one because it actually tastes good and doesn't have a funny aftertaste. And maltodextrin, which is these are the two: sulfame potassium, maltodextrin, which kick me into a kidney stone. Those are the sweeteners that are problematic. So and I accidentally left off of this slide aspartame. Aspartame I used to be a fan of because it suppressed appetite. However, what we found is that in a couple studies that aspartame itself actually stimulates insulin resistance in your gut bacteria as well. And that takes, and in me, it took about 14 weeks for that to correct. I've seen that with other patients as well, where it takes a little longer. It takes 12 to 14 weeks to get that correction to occur. And aspartame, though it doesn't raise insulin, it doesn't raise blood sugar, it keeps the gut bacteria from being able to produce butyrate, which is a form of a ketone, as it breaks down your fats in your gut and causes this gut-based insulin resistance, essentially, is what it happens. It also affects the mitochondria in some adverse ways as well, which we're learning about in the last year and a half. So I need to add aspartame to that, and I forgot to add that to the slide, but I may put that on here. I would say put that on there. And then excessive protein intake. Now, a lot of people say, well, Dr. Nally, your protein doesn't convert to sugar. No, it doesn't. But many of the proteins stimulate an insulin response and participate in the Krebs cycle by themselves. And they can actually, where they participate in the Krebs cycle, they spike insulin, and they can actually drive the process of an increased insulin response and halt weight loss and some of the other diseases of civilization as well that way too. So something to consider. So calorie restriction. Well, what's the challenge with calorie restriction? Well, when you restrict your calories, we know that calorie restriction will actually lower testosterone up to 50% within 7 days. And so I'm not a huge fan of prolonged calorie restriction, nor am I a huge fan of excessive fasting. I'm a fan of intermittent fasting, very short periods of time, fasting periodically, but I'm not a fan of this repetitive fasting for prolonged periods of time because of this testosterone issue that rises, because of the way that actually affects adversely your fat cells' ability to handle fat and release fat. So there's a fine balance there. Some people say, well, you don't like fasting. No, I love fasting. Fasting is great, but excessive fasting can cause problems. And so you have to understand how you're using that fast and why you're using that fast and what it's going to do to you metabolically. Again, we talked about excessive exercise. It also lowers testosterone as a problem. And large calorie restriction also pushes that down even more. So when you exercise your brains out and you don't eat, this is what happens. You actually see a drop in your testosterone. You stop losing weight. You feel more fatigued. You feel horrible. It actually starts to adversely affect your growth and your hormones and your muscles. So something to consider there. In the normal male, the green is the normal male, you can see testosterone. This is the male testosterone levels. This is his free testosterone. This is sex hormone binding globulin. What we notice is that as you gain weight, we see a natural suppression in testosterone in men. About a third of the men that come to me have testosterone below the normal level all the time. And that's because they gain this weight, and the metabolic syndrome, the hyperinsulinemia, adversely affects the production of testosterone. And so we'll look at that here for a second. So what happens, again, you've got the brain, the hypothalamus, stimulates that. Again, that anterior pituitary gland plays a role here, but it's producing not thyroid hormone this time. We're talking about luteinizing hormone and FSH, stimulates the testicles to produce testosterone. The testosterone then feeds back up and tells the brain how fast that testosterone is being produced, and it's got this nice balance. It's called the male hypothalamus pituitary gonadal axis. The challenge is, again, when we have high insulin, we have a lowering of leptin. Remember, leptin's high, but leptin can't get into the brain, so the leptin's low. And when that leptin's low at the brain level, it actually slows the release of gonadotropin, which then slows the release of FSH and LH. And the high insulin, through the process of CGRP being high, has an even more inhibitory effect on luteinizing hormone, which then dramatically slows down the production of testosterone. Now, this is not all. What ends up happening is because of adiponectin being low as well, because when your fat cell gets bigger, you see a decrease in adiponectin production, not an overproduction. It actually lowers sex hormone binding globulin, and that also has a suppressive effect on the formation of testosterone. So from 3 or 4 different angles, you have a significant suppression on testosterone just because of high insulin. And that's what drives this. I mean, there are whole markets for men on testosterone because of this issue. So it's important to understand there. In the female, same thing's happening. you get this. But what the driver is slightly differently is the adiponectin. The way the female hormone works is that you actually don't suppress FSH as much, and you get an overdrive of testosterone production and an underdrive of estrogen production. And it's a little more complex, but what happens is the insulin actually amplifies the production of testosterone at the ovary, where it suppressed the LH. So you'll see this shift in the way estrogen is formed, but an increase in testosterone. And this is where PCOS arises from, because of that high insulin drive. So the high insulin drive is adversely affecting the ovary differently than it affects the testes. So something to see there. This is just another slide to show you that you get this overproduction of testosterone, and it's not spelled there right, pardon me. You get this overproduction of testosterone because of the drive of insulin on this whole system. All right, so basics. Keep your carbohydrates low enough. You don't want to keep them under 20 grams per day for weight loss. You want to keep them less than 10 to 20 grams per meal if you're just wanting to reduce cholesterol. We want to get the ketone levels above 0.5 millimoles. We know that above 0.5 millimoles is the effective level for a true nutritional ketosis. For weight loss to be effective, I usually want to see that somewhere between 0.8 and 1.5. Higher than that means you're probably overloading yourself with MCT oil, but usually somewhere in those ranges is where we see that. We want to moderate the protein. Now, I know there's argument about, I should do high fat, low protein, or low protein, high fat. We want to moderate protein so that your body is able to maintain muscle, maintain skin, maintain hair. And that's the most effective method. Some bodybuilders, because of the excessive amount of muscle they use, can do large amounts of protein, and they need it. But the average guy like me who burns 300 calories in the office, running from room to room, jump to conclusions, sitting in the chair most of the time, I don't need that much protein. All right. I tell people that they should be closely monitored by their physician, because I often have people cut their carbohydrate back and they see improvement in blood pressure and improvement in blood sugar and improvement in blood cholesterol. However, the challenge is their blood pressure suddenly normalizes and their cholesterol normalizes, but they're still taking 4 blood pressure pills. And they'll have notable, passing out episodes or lightheadedness because of these issues. So if you're on any medicine whatsoever, very important that you see your doctor. Very important. Listen to me. Go see your doctor. Use long chain fatty acids for hunger and appetite suppression. These are essential. Long chain means the coconut oil. So I'm not a big fan of using the MCTs and the brain octane, because they don't give you the appetite suppression that using real coconut oil or real olive oil does. That's what I'm looking for. Exogenous ketones in my book should not be taken with MCT for weight loss, because it actually inhibits each other. And the process I kind of explained, and I can explain it in more detail, but they inhibit each other. I use exogenous ketones with weight loss, but I don't try to add MCT to it because of what it's doing. This is you're just basically shooting yourself in the foot because of the way the body's partitioning fuel. All right. Let's see. I'm going to move on here. So I already put that in. We already saw that slide. I apologize. All right, so start by substituting foods. We use substitutions. If you were using chips, substitute pork rinds. If you're using soda, switch to sparkling water. If you've been using cookies, switch to fat bombs. I find that people do better if I can give them a substitute. Essential resources. Look for good cookbooks. Maria does a great job. She's on here, and a number of the other people that are on here that do recipe generators are fantastic. A good journal. Journal is important, and I can't emphasize how important that is. That's what we use in my membership site. It plays a big role with cognitive behavioral therapy. You need a partner, someone that can be a teammate with you, and support groups. And that's what I do with my programs. Is we have an online private Facebook group, which is a support group that helps people use the journaling, use the partnership, and use the support group that way. So I find those are really, really helpful for people, if you want to consider that. These are foods that work great to stabilize ketosis: bacon, eggs, hard cheeses, meats, porks, fatty fish, butter, heavy cream. Be careful with the dairy with some people that may have dairy sensitivity. Avocado. I have a lot of people that overdo avocado. One avocado is 18 grams of carbohydrates, so be aware of that. Overdoing avocado is huge, and I tell people be cautious with the avocado amount. It's a great food, but it does have some carbs in it. Peely nuts, macadamia nuts, almonds, and walnuts are great. And then exogenous ketones we talked a little bit about. All right, well, that's the end. I think I went over time, and I apologize for shooting over that. Hopefully that's not going to cause anybody's delay in their schedule, but that's the end. So you can find me at docmuscles.com. Dr. Nally at drmuscles.com, Twitter at Dr. Muscles. I'm on Facebook. Look me up under Dr. Adam Nally. This is my membership site. You can see there, and then these are the components that I've got. So I appreciate your time being on here. Shoot me a question. Check me out online. And again, thank you for letting me participate. And hopefully you learned something, and hopefully I've been able to give you some great value today. Take care, guys. Have a great day. Remember, keep the fat high, keep the carbs low, and pass the bacon. Take care, guys.